fourth year medical student at Al Faisal. And inshallah, we'll be talking today about acute renal failure. So I want to make, just let you guys know, first of all, that this session is for you guys, and make sure that anytime you guys have a question, you guys can unmute yourselves or write in the chat. Just stop me whenever you guys want, and I'll, answer the questions to the best of my abilities, inshallah. So to start off, I want to make it clear we're going to be talking about acute renal failure. So obviously in renal failure, we can divide it into acute versus chronic causes. So acute renal failure is defined as decreased in the creatinine clearance. We'll talk about this more in details, but it's also associated with something called uremic symptoms. We'll also be explaining this as well. And it's divided into mainly pre, post, and intrinsic renal failure. On the other hand, you have chronic renal failure. Now, this is over time, over years, over months of deterioration and dysfunction of the kidney, usually due to diabetes and hypertension. You'll have what you call chronic renal failure, and the symptoms are usually in the later stages. Much different than acute renal failure. Well, you'll have symptoms early on. So to start off, I want to define the symptoms of renal failure. So we can divide renal failure into azotemia or symptoms, azotemia and uremia. So the difference between them is that azotemia is defined as insufficient filtering. So you have insufficient filtering by the kidney. Now this is without symptoms. So uremia is azotemia with symptoms. So these symptoms include the following: anorexia, nausea, vomiting. Let me use the pointer, 1 second. Pointer options. Anyways, so the uremic symptoms, as I was saying, include anorexia, nausea, vomiting, platelet dysfunction, which actually cause bleeding, pericarditis, asterixis, and encephalopathy. So these are all different symptoms that a patient could present with the findings of insufficient, filtering of the blood by the kidneys. So that's uremia. Now, as we said previously, we can divide renal failure into 3 separate causes, or 3 separate categories, you could say. So the first category is what we call pre-renal. So this is before the kidneys, anything that's affecting the blood flow. So the definition of pre-renal failure is any singular cause that causes a decrease in blood flow to the kidneys that will cause renal failure. This could be shock. I listed a couple of causes here, such as dehydration, shock, heart failure. All of these cause what we call, or in general, cause a decreased blood flow or renal blood flow to the kidneys, and that is what's causing the pre-renal failure. Now, another category is what we call post-renal failure. Now, this is obstruction of the urine outflow, okay? Now, this could be anywhere along, the urinary tract from the kidneys all the way to the urethra. Anything that's blocking the urine, however, specifically, it should be bilateral. And what's the reason for this is because if it was unilateral, the other kidney will compensate. Therefore, it has to be bilateral obstruction, whether it's in the ureters or in the bladder or wherever the obstruction may be. It has to cause bilateral obstruction to both kidneys. Now, examples, as you can see, we have kidney stones, BPH, tumors, and other congenital anomalies, but these all have to cause bilateral obstruction in order to cause renal failure. Now, the third category is what we call intrinsic renal failure. This is divided into mainly 2 causes: acute tubular necrosis, okay, and glomerulonephritis or acute interstitial glomerulonephritis. And this is, of course, intrinsic is due to dysfunction to the actual kidney itself, and that is what's causing the renal failure. Now, I want to make the labs very clear before we go on. I want to define certain characteristics that we should point out or look towards before we go on to dividing or seeing what characteristics of each category has. So for example, we have these following labs that I put down here. So creatinine. So creatinine, specifically, physiologically, is freely filtered by the kidneys and has a small amount secreted. This is why we use it to estimate GFR, because it's the closest thing to an item or a substrate that's freely filtered without being absorbed or secreted. The slight issue is that it's a small amount is secreted, which is why it's not the perfect substrate, but it's the best that we have, or the most easy access we have. Second, we have what we call BUN, the blood urea nitrogen. It's freely filtered as well, and is actually reabsorbed when the kidneys are reabsorbing water. So when the kidneys are retaining water, it will absorb BUN with it, okay? So this is important later on. We'll explain this again. The normal ratio is 20-1 or 15-1. Resources may vary up regarding this. However, this is around the normal ratio. The urinary sodium is the amount of sodium present in the urine. So when you're testing the urine, you will test how much sodium there is, and this is what the value urinary sodium is. And normally it's variable. It depends on how much sodium you're intaking. If you're eating a lot more salty foods, so it's variable normally, but it is very low when the kidney is retaining water and salt. So why is that? Physiologically, if you're retaining salt and water, you're removing it from the urine. Therefore, it's going to be low in the urine. And the value of a low urinary sodium is less than 20 milliequivalents per liter. Now, the FeNA, or the fraction excretion of sodium, is a different value. It's actually the percentage of sodium that was filtered. So let's say 100 is filtered, okay, in the kidneys. What's the percentage of sodium that we found in the urine? Now that is this value, that's FeNA. So again, it's the amount of filtered sodium that is excreted, and is again very low when the kidney is retaining salt or water. Now why is this? Because if you have, let's say 100, let's say for example, I'm just giving a value, 100 sodium filtered from the GFR, and the kidney is really retaining water and sodium, so it reabsorbed 99 of that. You only have 1% left. So the more the kidney is retaining water and sodium, the less the FeNA will be, and it will be less than 1%. Okay. Now, the urinary osmoles is essentially how the ability is able to concentrate. This is the value that it gives us. So if the kidney is retaining water, okay, if the kidney is retaining water and salt, there's going to be an increased amount of salts or increased amount of solute in compared to fluid. Therefore, the urinary concentration is going to be very high because you're removing all the water. You're going to have very high concentration of urine. Okay. So now the first category is what we call, again, pre-renal failure. So this is due to, again, decreased blood flow to the kidneys, whether that be dehydration, shock, any cause, or heart failure. Anything that causes decreased blood flow to the kidneys will cause pre-renal failure. So you're going to, because there's decreased blood flow, decreased RBF or renal blood flow, you're going to have less BUN and creatinine filtered through the kidney. Now, this will cause a rise in BUN creatinine in the blood, okay? So next we can see here, there's going to be more resorption of water. So after you have a decreased filtration of BUN and creatinine, and it's going to be elevated in the blood, your body is now dehydrated or has low blood flow. So the kidneys sense this and will cause increased resorption of water. So if you have a decreased amount of blood flow to the kidney senses this and thinks that you're having a blood loss or anything, and a compensatory mechanism is that it will cause increased reabsorption of water. Now, what did we say beforehand? We said that BUN will follow water, okay? So now that the kidneys are still functional, the only difference is that there is a decreased blood flow. So with the increased reabsorption of water, you're gonna have an increased BUN. So that's why in pre-renal failure, the BUN rise is much higher than the creatinine. because as we said before, creatinine is freely filterable and secreted, not reabsorbed. However, BUN will follow water, so it's freely filtered and will follow water if it's being reabsorbed. So again, is that clear with everyone? Is that clear? So again, one more time, I'll just explain it. There's decreased blood flow to the kidneys, okay? And this will cause a compensatory mechanism by the kidneys. It will want to reabsorb more water. Now, doing this will allow the BUN to follow with the water. So we can have increased reabsorption of BUN. Therefore, two things are happening right now. First of all, there's decreased blood flow, which causes a decreased filtration of B1 and creatinine, therefore a rise in the blood. Second of all, because there's increased reabsorption of water, the B1 will also follow it. So anything that was filtered, which is also low, will actually be reabsorbed with the water. So there's two mechanisms, okay? And this is why you're gonna have a much higher BUN compared to creatinine. And the ratio will be more than 20/1. 22/1, sorry. Now, urinary findings of pre-renal failure. You're gonna see lots of water reabsorbed, again, as a compensatory mechanism. The urine is gonna be very concentrated, again, because you're gonna be reabsorbing the water. The osmolality of the urine, again, as you said, will be very high because you are reabsorbing the water. So what's going on is because of the compensatory mechanism, let me repeat this concept again. So the blood flow to the kidneys, as we said, is low. The kidneys will compensate by increasing the water reabsorption. So the reabsorption of this water will cause many things. It will cause BUN to follow it, leading to a very high increase in BUN. It will cause decreased amount of water excreted in the urine. Therefore, you can have very high concentrated urine. So the urinary osmo will be more than 550. A loss of sodium will follow the water as being reabsorbed. So this is why you have a decreased urinary sodium and a decreased fractional excretion of sodium. So this is all the findings of pre-renal failure. And remember, stop me whenever you guys want. You can unmute yourself or put the question in the chat. And inshallah, I'll answer those questions. So intrinsic renal failure. So the kidneys cannot filter the blood. So this is either caused by ATN, acute tubular necrosis, or acute interstitial nephritis. So there's dysregulation or dysfunction in the kidneys themselves, okay? They cannot filter the blood. So again, this leads to decreased filtration of the BUN and creatinine and an increase of BUN and creatinine in the blood. Now, the difference here compared to pre-renal failure, is that the kidneys themselves are dysfunctional and they cannot reabsorb the water. Therefore, you're not going to see a very high increase in BUN because not following the water as it did in pre-renal failure. Therefore, the ratio of BUN to creatinine will be less than 15 or at the normal range. Now, for the urinary findings of intrinsic renal failure, first of all, we can see that the kidneys cannot reabsorb the water. As you said, the kidneys themselves are dysfunctional. The tubular cells cannot reabsorb the water. As a result of not reabsorbing water, the urine osmolality will be low. That means the concentration is low because there's a lot of water that cannot be reabsorbed. Therefore, in the urine, you're going to have a low urine osmolality. And again, because of dysfunction of the tubular cells, you're going to have a high amount of sodium in the urine, which is the UNA, the urinary sodium. It's going to be high because you cannot reabsorb it due to the dysfunctional nephrons. And lastly, you're going to have also a high fractional excretion of sodium because you cannot reabsorb the sodium again. Now, for post-renal failure, this is due to obstruction, as we said before. And the obstruction has to be bilateral and blocking on both kidneys. And you're going to have backing up of the urine. Now, what this does is going to cause high pressure in the tubules, which will cause decreased filtration of BUN and creatinine. So this is the reason why you have a high, or renal failure in general, due to obstruction, is because of the backflow causing increased tubular pressure. This will decrease the amount of filtered blood there is and decrease the amount of filtered BU1 and creatinine as a result. And eventually over time, initially that the tubular cells will be functional. However, we realize over time, due to the high pressure, is going to have you're going to have dysfunctional nephrons as a result. So with post-renal failure specifically, diagnosis is not really made by plasma and urine. Now, what's the reason for this? Is because the values are variable, variable in response to different mechanisms. For example, early responses to post-renal failure are more similar to pre-renal failure. And what's the reason for this? Is because the tubular cells are still functional. However, I'm going to show you guys that later on, the tubular cells become dysfunctional, and you realize the findings become more like intrinsic renal failure, because as a result of the high pressure, the tubular cells are dysfunctional and the nephrons become dysfunctional. So this is why we don't really use diagnosis using the urine and the plasma. The main features of or the main method of diagnosis is with renal ultrasound. And what you see is you're going to see two things. You're going to see enlarged kidneys and enlarged ureters if the obstruction is in the ureters. And most importantly is, if you're seeing a question or a patient in general, how would you know this is post-renal failure? If you're seeing that they have uremic symptoms, astrixis, nausea, vomiting, different symptoms that indicate that this patient may have renal failure. How would you know it's post-renal if we said that you can't use the plasma or urine because it's variable? You look at these two main symptoms or two main features of the patient. If they're anuric, so anuric, they have no, they're not urinating at all. And this would be a very alarming symptom, means that there's an obstruction. There's an obstruction, they cannot urinate. The patient cannot excrete any urine. Second of all would be hydronephrosis, as we can see on the ultrasound. This indicates, of course, a backup of fluid secondary to the obstruction, and this would be most likely the cause of renal failure. So these two features are the most important features in diagnosing renal failure. So the findings, as I said, the urinary findings are variable and they're not the most important to use. The most important thing is to use the ultrasound. However, as we said initially, the tubular cells are still functional, okay? Therefore, it will mimic pre-renal failure in the reabsorption of water. So therefore, the urinary osmoles will be high, so more than 550, because the tubular cells are still functional and can still reabsorb that water, which will allow concentration of the urine. However, long-standing post-renal failure, the nephrons themselves become dysfunctional due to the high pressure, and this will cause the concentration of the urine to decrease because you cannot reabsorb the water anymore. And the BU1, creatinine, the urinary sodium, the FeNA are all variable, again, in post-renal failure. However, again, most likely in early post-renal failure, you're going to have symptoms and clinical findings that mimic pre-renal failure, and in long-standing, it'll mimic intrinsic renal failure. Okay, so we went over a lot of concepts so far. Does this make sense to everyone? Does anyone have any questions at all? If not, we can move on. Sounds good. So now we're gonna go mainly over the doctor slides now, which I think Dr. Khalid took this lecture. Last year we had Dr. Majid who took this lecture. And for some reason, Dr. Khalid really emphasized on a lot of unnecessary things, in my opinion. And that's why I made a lot more concept slides myself for acute kidney injury in the first hand. And we'll go over his slides shortly in a more summarizing fashion, and not in depth, because I don't think they're that relevant, to be honest. And hopefully the concept slides that I gave beforehand are the most, I believe, are the most important actually. So when we talk about GFR, Again, as the doctor says, they're mainly used in CKD, not AKI, because it's used for staging in the chronic kidney disease, as you guys know. And acute kidney injury, you cannot really use GFR because the nephrons are still functional, so it's not really used for acute kidney injury. And again, as for CKD prognosis and progression and staging and drug dosing, so it's not really used for acute kidney injury. And this is how you calculate it, of course. We use urine concentration of whatever, times that by the urine volume divided by plasma X. So the ideal solute for GFR is one that is actually freely filtered and neither secreted or reabsorbed. So as we said, creatinine is slightly secreted. Therefore, it's not the most optimal, but it's the most frequently used because of its easy access in a patient setting. So again, it's the ideal solute would be naturally made endogenously. So you don't have to insert something in the patient to find out the GFR. So that's the most ideal, that the patient already makes it himself, his own body makes it. Secondly, that it's 100% freely filtered by the glomerulus. Because if it's not, then therefore it cannot fully calculate the GFR, because then you're not seeing the full scope of the picture, you could say. And it should be neither secreted or reabsorbed by the tubules. So again, as I said before, the limitation of creatinine is actually sometimes may reflect muscle mass. So a bodybuilder may have a high creatinine even though their kidney function is normal, and in specific populations they may have it low to normal. So other methods to estimate GFR, as we can see, there's exogenous filtration markers such as inulin, isothalamate. You've all seen these before. However, they're very inconvenient when in a patient setting. So ideal clinical setting, you won't want to use these because it's very, unnecessary for the patient to be injecting them with one of these substrates just to calculate the kidney, the GFR. So in clinical setting, we don't really use these. Okay. So again, acute kidney injury, we already went through this definition. So a sustained increase in BU1 creatinine. This is the main definition of acute kidney injury and how you define it, as well as the urine output. Now, this slide is purely memorization. And the reason why he shows you this slide, he won't really test you on this. The only difference is that he wants you to understand that there's different stages. So these stages will just tell you how severe this renal failure is in the patient. Okay. So these slides from here on are going to show you the mechanisms of the three categories as we talked about before: pre-renal, intrinsic, and post-renal. And he just shows you diagrams on how to visualize these different categories. So he drew the glomerulus, the afferent and efferent arterioles. So in anything that affects the afferent arteriole will decrease the renal blood flow and decrease GFR. So this is what we see in the case of pre-renal failure. Okay. So different causes, we said this before, of pre-renal failure. Anything that causes a decrease in the renal blood flow will cause pre-renal failure. Hypovolemia, sepsis, congestive heart failure, cirrhosis, nephrotic syndrome. So all of these are essentially causing a decrease in the blood flow to the kidneys, and this is what's causing the renal failure. Now, post-renal failure, we could see as multiple causes. Anything that causes obstruction. Remember, we said it had to be bilateral obstruction. So it could be inside the kidneys, if it's casts, if they're big enough. It could be extrarenal, such as nephrolithiasis, kidney stones, bilaterally. It could be BPH, but this is much less common in intrinsic and pre-renal failure. And the reason being why it's much less common is because usually when you have obstruction in the path of the kidneys to the urethra, it usually is unilaterally. And as we said before, if it's unilateral, the other kidney will compensate and you won't have renal failure. So seeing a bilateral obstruction is much more rare than seeing the other two categories, intrinsic and pre-renal failure. So intrinsic renal failure, as we said before. So actually, this is the most common inpatient cause of acute kidney injury in hospitalized patients. And the reason being, as I've searched this up before, is due to the medications that an inpatient person usually is on. They have a much more likely cause of getting intrinsic renal failure than the other causes. And it's a much more difficult diagnosis than the pre-renal and post-renal failure, you could say. And it damages all three of these, the tubules, vessels, and the glomerulus. And this leads to internally, dysfunction of the kidneys and inability to filtrate the blood. I feel like I'm going too quick. Is there anyone? Someone asked, how is nephrotic pre-renal? Okay. Let me go back. Where was that? Someone asked, the reason why is because in nephrotic syndrome and cirrhosis as well, you're gonna have a lot of edema. This leads to decreased intravascular volume, and that in turn leads to a decreased renal blood flow. Does that make sense? So because cirrhosis and nephrotic syndrome are indirectly leading to a decreased RBF, not directly. Does that make sense? Okay. Where were we? Okay, so this is a nice slide trying to, separate the categories or causes of intrinsic renal failure. So you have diseases that affect the tubules, such as ATN, which is the most common, and acute interstitial nephritis. You have vascular causes, such as an emboli or thrombosis. Okay, and the way that a vascular, cause or disease that can cause intrinsic renal failure is due to ischemia. Is due to ischemia of the nephrons, and that in turn leads to a result of dysregulation and dysfunction, and the kidneys cannot filter the BU1 and creatinine anymore. And then other causes are anything that affects the glomerulus, such as glomerulonephritis and renal vasculitis. This slide is summarizing, the causes of acute tubular necrosis. So acute tubular necrosis could be a result as ischemia and sepsis, which is more common. And the other cause could be direct toxins. Now, these direct toxins, again, can be divided into two things. Exogenous could be medications, contrast, antibiotics, other toxins extrinsically or exogenously. Endogenously could be diseases such as rhabdomyolysis. And this is, they're toxins essentially that will cause, acute tubular necrosis and in turn, renal failure. Now, this is simply an incidence graph showing you again that inpatient or in the hospital, most common is intrinsic, while outpatient is more likely pre-renal. And yeah, that's simply it. Now, when we talk about diagnosing acute kidney failure, so workup is essentially what workup means is the steps of investigations that you will do to diagnose this patient. So the first step is always in any patient in a physical exam or any patient you will find, you want to do a physical exam, you want to do vital signs. Now, what is the most important thing in relation to renal failure in the vital signs, and that is the blood pressure. Now, why is this? This is because if the blood pressure indicates that there is hypotension, you already have your diagnosis. You know, the most common cause, the most likely cause, if they have hypotension, is pre-renal failure. And you will confirm this with your laboratory findings, as we said, in the urine and the plasma. However, if you can, in the vitals, already find out that they had hypotension, this helps your diagnosis a lot. Secondly, you want to look for signs of edema, hypovolemia, or obstruction. So these will, of course, tell you if it's edema. If you see a lot of edema or hypovolemia, this will indicate more of a pre-renal cause, and obstruction will tell you this most likely a post-renal cause, and you might want to go for an ultrasound. The lab findings, as we said, lab investigations. You want to, of course, do a renal profile. And you want to check the plasma. You want to check for urea, BUN, creatinine, as we said before. You want to also check the CBC, ABG as well. And of course, we do a urine analysis and urine chemistry, as we said before. Now, these are also tools that help diagnose, acute renal failure. So specific gravity, protein, hematuria, ketones, nitrates, leukosterase. However, they're much less common and much less important as compared to other investigations. Now, from here on out, the doctor's slides are very random, and I don't know the whole goal of the slides, but we'll try to cover them. These are the different cats. I can't really explain much in these pictures, except that these are the pictures, and you guys should try to memorize them. I know it's difficult, but that's all I can really say. How do you distinguish between the three causes of renal failure? We've talked about this before, but we'll go over this again. So in pre-renal failure, the BUN creatinine ratio specifically is more than 20/1. And we said before, the reason being is because in pre-renal failure, you're going to have a decreased blood flow. So this decreased blood flow causes a compensatory mechanism in the kidneys. So the kidneys sense that there's a decreased amount of blood flow reaching them, and they'll want to increase this. How do they do this? They want to increase the amount of water being reabsorbed. And as we said, when we reabsorb water, the BUN will follow. The creatinine will not, because the creatinine is only freely filtered and secreted. It is not reabsorbed. Therefore, the BUN will rise much greater than the creatinine, and you'll have a ratio more than 20/1. The specific gravity is going to be high as well, because you're going to be reabsorbing a lot of water, and you're going to have a lot of solute. So it's going to be concentrated and heavy at specific gravity. And as I said, the urine osmolality will be more than 500 or more than 550. And this is because you're reabsorbing a lot of water, and you're going to have a very concentrated amount of urine. The urine sodium itself, the amount of sodium in the urine is going to be low, because as we're reabsorbing water, the sodium will follow. And as you're reabsorbing a lot of sodium, you're going to have less sodium amount in the urine itself. And the fractional excretion of sodium is going to be less than 1%. Again, as a result of the increased water reabsorption and the sodium reabsorption as a result. So again, whenever we look at this, the best way is understanding the concept more than memorizing, because memorizing the numbers, you might get confused if one's less than 1%, 2%, all these numbers. If you just think about what's going on in the kidneys, is water being reabsorbed, and just follow as a sequence of what's going on, you will easily find, the values of these different categories and different investigations. Now, intrinsic renal failure has a normal BUN ratio of around 15 or 10 to 20. Specific gravity is going to be 1.01 or 1.02 on the lower scale, because you're not reabsorbing water. Therefore, there's a less, amount of solute compared to water. The urine concentration is going to be less than 350. And this is because the tubules themselves are dysfunctional. and the nephrons cannot reabsorb water. Therefore, you're going to have a low concentration. The urine sodium is going to be more than 30 because, as we said, you're going to have a dysfunctional nephron that cannot reabsorb. However, I want you guys to notice these two words: tubular versus glomerular. So tubular causes are going to affect the nephron, correct? While the glomerulus is going to affect much early on in the nephron. The rest of the nephron is normal. It's the glomerulus being affected. So the tubular causes are going to have high sodium. Now, why is this? Because the tubules themselves are responsible for reabsorbing the sodium. If they are dysfunctional, they cannot do this. Therefore, there's going to be a lot of sodium in the urine. If it's a glomerular cause, it's going to be low amount of sodium. Why is this? Because the dysfunction is in the glomerulus, not in tubules. So once the tubules can still reabsorb the sodium, therefore it's not going to be high in the urine. And the fractional excretion of sodium in intrinsic is going to be high, more than 2%. And as we said, this is because the nephrons themselves are dysfunctional and lead to decreased reabsorption of sodium. Therefore, you're going to have a high percentage of sodium in the urine. And again, I just want to point out that the tubular causes like ATN and acute interstitial nephritis are the most common causes. So whenever anyone's talking about what are the values here, make sure you're talking about the tubular causes and not the glomerular, okay? Now, for post-renal failure, as you said, the values here are variable. So early and late, you have to distinguish between them. As I said, early on, the nephrons are still functional. Therefore, it mimics pre-renal failure. So as we can see from here, in post-renal failure, early on, you're gonna have a high specific gravity, like in pre-renal. In late post-renal, you're gonna have low specific gravity, such as intrinsic. The urine osmolality is more commonly, such as intrinsic, low because there's gonna be decreased reabsorption of water. And again, the urine sodium, early on, it'll mimic pre-renal because the tubules are still functioning and they can still reabsorb the sodium. Therefore, you're going to have a less sodium amount in the urine. Later on, because of the high pressure onto the tubules, you're going to have dysfunctional nephrons and decreased reabsorption of sodium. And again, the FENA, same thing, same concept. Early on, it'll be just like pre-renal. And later on, it'll be more like intrinsic. Now, these slides are just showing you your analysis pictures, okay? Stuff you will find in acute tuberous necrosis, such as the muddy brown casts and all that stuff. Acute interstitial nephritis, you will see urine eosinophils, which is, there's always, whenever we see, when we talk about acute interstitial nephritis, I like to talk about three, very clear findings. You usually see fever and rash, okay, and urine eosinophils, okay, and as we said, urine eosinophils, blood eosinophils, and rash or fever within this onset. And the reason being is because a common cause of acute interstitial nephritis is drugs. So you're gonna have a fever and rash due to the reaction of the drugs, okay? And then you're gonna have eosinophils in the urine and the blood as a result of the hypersensitivity reaction. I like to point out that eosinophils are non-specific, therefore we usually don't test for it. However, they do like to ask about it, like, oh, if you see eosinophils, it's more likely acute interstitial nephritis. However, it is not specific. And these are other pictures for RPGN, which is not really the topic of our lecture, but I don't know why he put them in this lecture. And these are crystals you'll see on urine, which will indicate, an obstruction. If you see these crystals, you'll think, oh, there's more likely going to be post-renal failure due to obstruction. So acute interstitial nephritis, okay, mainly caused by infections and medications. So these are the most common causes, which is NSAIDs. NSAIDs are very, very common cause of acute interstitial nephritis. And all these other drugs can all cause, acute interstitial nephritis. Other investigations in general are renal ultrasound, and this is mainly when you're suspecting, post-renal failure. So on physical exam, you see findings that point towards post-renal failure, such as we said before, if they're anuric, meaning they're not excreting any urine, you would likely go for an ultrasound. You want to rule out, post-renal failure. Now, uremia and azotemia, as we said before, are the hallmarks of renal failure. Okay. Hyperkalemia can be caused as a result, as well as acidosis, hypervolemia, anemia, and other causes. So the reason why is all due to the kidney dysfunction. So all of these causes are caused by kidney dysfunction. For example, uremia and azotemia, all these are caused by decreased filtration or dysfunctional kidneys in general. Such as the anemia, it could be anemia of chronic disease. Hypervolemia is due to, increased reabsorption of water. Hyperkalemia due to, decreased filtration. So these are all caused by the renal failure itself. Now, when you have an elevated urea, is it uremia or azotemia? We already made the distinction beforehand. Azotemia is simply a clinical investigation where you see that there's an increased BU1 in creatinine, or increased BU1, sorry. Uremia, on the other hand, is you have an elevation of BU1 with the uremic symptoms, as I said beforehand, like asterixis, nausea, vomiting, anorexia, the different types of symptoms. But if you have an elevation of BUN and these different symptoms, now it's called uremia. We went over these symptoms beforehand. So nausea, vomiting, fatigue, decreased appetite, low energy, constipation, seizure, encephalopathy, pruritus, sleep disturbance, chest pain. These are all common symptoms of increased uremia. So pruritus, very common symptom. They're very itchy. You have itchy skin. Chest pain, it can cause pericarditis, uremic pericarditis, as you've learned before in your CVP block. Nausea, vomiting. These are all symptoms of uremia. And when you see these symptoms in a patient, you want to order the different investigations to rule out renal failure. Now, the treatment is dialysis. So you're filtering the kidney, you're doing the kidney's job. You're filtering the blood for the kidney. And that's simply what dialysis is. Now, these next few slides are really not with the scope of our lecture. So I'm going to cover them very, minimally and superficially, because I don't know why the doctor made a completely, sidetracking and made different slides for hyperkalemia for some reason. So hyperkalemia is mainly divided into three separate causes. So we can divide it into increased intake or a potassium shift from intracellular to extracellular, or a decreased excretion. Now, the third cause, which is decreased excretion, could be due to acute kidney injury, as we said beforehand, or the second cause, we can read right here, is the inability to excrete potassium without AKI. So how would you not be able to excrete potassium if you don't have AKI? That's due to certain drugs, such as potassium-sparing diuretics. So these will spare the potassium. The kidney is still functioning normally. However, you're going to have hyperkalemia as a result because you're sparing the potassium and not allowing its excretion. Now, these are different medications causing AKI, as we talked about beforehand, or hyperkalemia. Sorry, these are causing hyperkalemia, as we said beforehand, and they cause AKI, which will lead to hyperkalemia. So management, you want to order an EKG to rule out any arrhythmias. You want to check for hemolysis, which could lead to, a pseudo hyperkalemia, as we could say. And you want to order insulin. So these are all clinical stuff, and it's not really relevant to you guys. You want to order insulin because insulin will cause, increased potassium intracellularly versus extracellularly. So you're reversing the mechanism of hyperkalemia. Albuterol, and also order calcium. The treatment are 3 treatments. You can use potassium binders, okay, furosemide, and dialysis. So the doctor really did not cover, I checked your guys' video because we didn't have this lecture last year. He did not cover these cases, so this will not be in my scope of my lecture. However, if you have any questions regarding them, I'll be more than willing to answer them. Now we're gonna go over some questions. So I'll read the question, and if you guys can just answer in the chat. I think there's only one person participating. But yeah, we can see. So the first question is, a 67-year-old man is brought to the emergency department because of worsening shortness of breath. His symptoms are more severe at night when he lies down. He has a long-standing history of congestive heart failure. He recently stopped taking his medications because he could not afford to refill his prescription. He says that over the past few days, he has been producing less urine, and his pulse is 104 now. Now, physical exam shows bilateral coarse crackles on aspiration. His serum creatinine is now 2.3 milligrams per deciliter. The urinalysis shows no casts. So which of the following additional sets of lab findings is most likely seen in this patient? Okay. So the answer, okay, someone answered D. Okay. I don't think there's anyone else, so we'll explain the question. So the answer is actually B. Okay. So why is this? Okay, first of all, let's see the answer D. Who answered D? So they said the B1 will be 90, the urine osmoles will be 300, and the urine sodium will be 15. Okay, so I can tell that two of these are correct, one of them is incorrect. Now the incorrect one is the urine osmolality. So let's go back to the question and see what this patient had. So he's a 67-year-old man brought to the emergency because of worsening shortness of breath. Okay, when you see a shortness of breath, and he says he has a history of heart failure, now you think of causes of pre-renal failure, okay? Pre-renal, correct. And he stopped taking his medications. So now you think, okay, he's worsening his heart failure. He could have renal failure. So it's asking you what set of laboratory findings are most likely seen in this patient. So as I said, pre-renal failure before causes the kidney to have a compensatory mechanism of increasing the water reabsorption. So with this water reabsorption, it causes multiple things. It causes a very high B1, and it causes increased urine concentration because you're increasing the water reabsorbed, so the urine osmoles will be more than 550, okay? And the urine sodium will be less than 20 because you're gonna cause increased reabsorption of water with sodium. So this this compensatory mechanism of the kidney will cause all these findings. So the water will be reabsorbed. This will cause increased BUN reabsorption and increased sodium reabsorption. As a result, you'll have high BUN and a very high amount of urine concentration, which is represented by the urinary osmoles, and a very low urine sodium because you're going to be reabsorbing most of the sodium. So the answer will be B. So the BUN will be very high, the osmoles will be more than 550, and the urine sodium would be less than 20. Does that make sense? Okay. So the second question. So 2 days after going an emergency laparotomy with a splenectomy for a grade 4 splenic laceration sustained in a motor vehicle collision, a 55-year-old man develops decreased urine output. His urine output is less than 350 a day, despite aggressive fluid resuscitation. During the emergent laparotomy, he requires 3 units of packed RBCs. He has type 2 diabetes and is on an insulin sliding scale. His vital signs are within normal limits. Physical exam shows a healing surgical incision in the upper abdomen and multiple large ecchymosis of the superior right and left abdominal wall. His hematocrit is 28. His platelets are 400,000. Serum creatinine is 3.9, and the BUN is 29. The urinalysis shows brown granular cast. Which of the following is the most likely underlying cause of these findings? Does anyone want to answer? So someone put F, acute renal infarction. Now, the cause is actually, the answer is actually A. So acute tubular necrosis. Now, why is this? First and foremost, the acute tubular necrosis, as I said before, is the most common cause of intrinsic renal failure, okay? So we see here in this patient, okay, he has prolonged hypotension. Now, let me see this. He is very low urine output, okay? And he has prolonged hypotension and surgery. He had surgery for splenectomy and ischemia. So the ischemia necrosis does not lead to an infarct. Acute renal infarction is mainly associated with thromboembolism, okay? So this patient does not have any, cause that will increase his likelihood of developing an embolic, an embolism, and most commonly an acute renal infarct is caused by congestive heart failure. So what happens is there's a heart failure and an increased amount of pooling of the blood that leads to a thrombus formation, most commonly in the left atrial appendage. As a result, an emboli will leave this thrombus and occlude any organ with very high blood flow. So the two most common organs are the brain and the kidneys, okay? However, in this case, the patient did not have any of those findings. He didn't have congestive heart failure, nor an ultrasound showing the picture of a renal infarct, or pain. Acute renal infarct will have back pain. So none of these symptoms shown in the question will be associated with F, acute renal infarction. However, we can see in this patient that he had required 3 units of RBCs. That means he had a very low amount of blood and a blood flow to the kidneys. His hematocrit was very low, and that his serum creatinine is 3.9 and his BUN was 29. Now, this is most commonly associated with the intrinsic renal failure, and the most common cause is A, acute tubular necrosis. Brown granular casts are, what is the question asking? Brown granular cast, I didn't understand the question. Can you? Are they RBCs? No. They're essentially, what's happening is that what's going on, you're asking essentially the muddy brown casts or the brown granular casts. Are they the same thing as are they RBCs themselves? So what's happening is, no, it's not actually RBCs. So what's happening is that, to my knowledge, it's a degeneration of the casts themselves, composed of hyaline. So hyaline casts are seen in a normal person. Okay, it's a non-specific finding. However, due to sloughing of tubular cells due to ischemia in these patients with acute necrosis, because they're having necrosis to the tubular cells, as the cells become ischemic and necrotic, they slough out and form a cast. The reason why it's muddy, and that's why it's called a muddy brown or granular cast. It's originally a hyaline cast, but due to the sloughing of tubular cells, it can cause, a muddy brown appearance, and associated with acute kidney injury. Tamam. Thank you everyone for this session. Hopefully it was, inshallah, useful for you guys. Again, if anyone has a question who couldn't ask in the session, you can email me or text me. My information was at the start of the lecture. I think they'll upload this, inshallah. Any last questions?
I don't think so. Okay, thank you very much, Abdulaziz. I'll stop the recording now.